Hello, and welcome to this special Breast Cancer Awareness Month episode of the VJOncology podcast. As October draws to a close, we take a closer look at the latest practice-changing developments in HER2-positive and metastatic breast cancer, as presented at the ESMO 2025 Congress in Berlin, Germany. In this episode, we hear from leading experts Professor Charles Geyer, Dr. Sara Tolaney, and Dr. Erika Hamilton, who discuss the evolving role of antibody-drug conjugates across the spectrum of breast cancer care. To begin, we hear from Charles Geyer of the University of Pittsburgh Medical Center, who discusses the results of the Phase III DESTINY-Breast05 trial, comparing trastuzumab deruxtecan with trastuzumab emtansine in patients with high-risk HER2-positive early breast cancer and residual invasive disease after neoadjuvant therapy.
DESTINY-Breast05 was really a follow-up study to a previous trial, the Catherine trial, that had established that adjuvant T-DM1 was very beneficial for high-risk patients who did not have a pathologic complete response with neoadjuvant therapy. The trial really created a standard for patients presenting with intermediate advanced disease to receive HER2-directed therapy, chemotherapy, many of whom will enjoy a pathologic complete response. It means they have a high probability for cure. If they don't, though, they are at risk for recurrence. And the study showed even small amounts of residual cancer still had the risk. And the great thing is T-DM1 cut the risk by 50%. It was a very large relative reduction. But we saw in the data that highest risk patients who presented with a locally advanced cancer, what we call T4, or heavy nodal burden, N2, N3, if they had any residual disease, they already, when we first looked at Catherine, by 3 years, nearly a quarter of them had already recurred. So it brought them a long way, but it still left this risk. The other group were patients who still had cancer in their lymph nodes. Wasn't quite as high. It was about 18%, but still you could see, because we knew that with time, those numbers were only going to get worse, and we indeed saw that when we took Catherine out to 7 years. But we didn't wait to start working on something better, because we were seeing already at that point what a remarkable drug T-DXd was. And we felt like we had enough evidence from both for efficacy and enough understanding of toxicities to justify taking it into the early setting in high-risk patients, which is what we did in DESTINY-Breast05. When we set the study up, we thought we would at least need to be able to see a further reduction by a third over what you could get with T-DM1. So we powered the study to detect a hazard ratio of about 0.67. But we knew that, and you always hope the drug's even better than that. And so you create these interim analyses points that will let you detect a larger effect. And we do the interim analysis. The statisticians say, well, you need 207 events to get that hazard of 0.67. You need about 3/4 of that to see something better. And that's what we saw. When we looked at our interim results, we saw a hazard ratio of 0.47, quite a bit better than 0.67, amounting to a 53% reduction in risk for the cancer coming back. The IDFS endpoint short term for that is how many patients are alive and cancer-free, which of course is what we want to see. And that's what the study showed that I was able to report yesterday.
Following on, Sara Tolaney of the Dana-Farber Cancer Institute highlights the practice-changing implications of the same trial. Dr. Tolaney notes that trastuzumab deruxtecan reduced the risk of recurrence by approximately 50% compared with trastuzumab emtansine, marking one of the most substantial advances in the adjuvant treatment of HER2-positive primary breast cancer.
I think the findings from DESTINY-Breast05 that we saw at ESMO this year are practice-changing. To me, there were some of the most exciting data that we saw at ESMO because it focused on a very high-risk group of HER2-positive breast cancer patients. So these were patients who had residual node-positive disease after getting neoadjuvant therapy or came in and presented with a tumor that was inoperable at baseline and then went on to have residual cancer. and they randomized them to get T-DXd for 14 cycles or TDM1. And they found that those patients who received T-DXd actually had a much better outcome. It reduced their risk of recurrence by half when compared to TDM1. It was an absolute difference of about 9%. And so to me, this is quite profound because the majority of events that we saw were actually distant recurrences, and it reduced distant recurrences by half. One interesting little tidbit was we were kind of curious to see if T-DXd could actually prevent CNS relapse, because in the original Catherine trial that had looked at the use of adjuvant TDM1, we saw no reduction in risk of CNS relapse. In this trial, DESTINY-Breast05, we saw that T-DXd did have a numerical improvement in terms of CNS events. So there were 8 fewer CNS relapses in the T-DXd arm compared to TDM1. It's early on. The median follow-up time is only about 30 months. So I do think we need to follow this out longer to see if this is a real signal. But I think is very, a strong indication that maybe T-DXd can do better than TDM1 even in the CNS. So I think exciting to see that.
Dr. Tolaney also comments on the broader impact of antibody drug conjugates in metastatic breast cancer, noting that these agents are now moving into earlier lines of therapy and across disease subtypes.
I mean, as we can see that ADCs are really shifting into the first line setting across disease subtypes, which I think is exciting to see. So we had seen data from DESTINY-Breast09 at ASCO, which had demonstrated that the combination of T-DXd and pertuzumab did much better than THP. At ESMO, what we saw were the subgroup analyses. So we saw outcomes, for example, by key subsets. So particularly those patients who had PI3K mutations, patients who had hormone receptor positive disease, and then outcomes based on whether someone presented with de novo disease versus recurrent disease. And in fact, very consistently across these groups, we saw that the benefit of T-DXd clearly outweighed the benefits from THP therapy. And so it really showed there wasn't a subgroup that was not benefiting, and that it was very uniform in the benefits for the combination of T-DXd and pertuzumab. So I think just confirming in essence what we saw from the primary results. In terms of ASCENT-03, that was trying to look to see if we could move sacituzumab govitecan, a TROP2 directed antibody drug conjugate, from the second line and beyond metastatic triple negative setting into the first line setting. It was specifically focused on those patients who have PD-L1 negative tumors or are otherwise not eligible to receive immunotherapy. And it randomized patients to sacituzumab or treatment of physician's choice chemotherapy and found a significant improvement in progression-free survival going from 6.9 to 9.7 months. And so I think seeing this also suggests that we can move sacituzumab into that first line triple negative PD-L1 negative setting. And so again, I think very exciting data to see these ADCs moving up in the paradigm for metastatic breast cancer.
Next, Erika Hamilton of the Sarah Cannon Research Institute shares insights into emerging ADC trials, including DESTINY-Breast11 and DESTINY-Breast05, which are advancing trastuzumab-based ADCs into the curative setting for patients with HER2-positive breast cancer.
We have a lot of antibody drug conjugate presentations at ESMO 2025 this year. Some key ones really are going to be DB05 and DB11. Those abstracts are looking at moving trastuzumab deruxtecan up into the curative setting for HER2-positive breast cancer. So DB11 is in the neoadjuvant space. We've already seen a press release that this is positive with about 11% improvement in pathologic complete response rate. And then DB05 is a Catherine-like trial, looking at patients that have residual disease after neoadjuvant therapy and looking at trastuzumab deruxtecan versus TDM1, which is our current standard of care, also a positive trial. And then the other big place we see antibody drug conjugates moving up into earlier line is in triple negative breast cancer. At ASCO, previously we saw ASCENT-04 looking at the subset of patients that had PD-L1 positive tumors, but here at ESMO we'll be seeing ASCENT-03 looking at sacituzumab govitecan in the first line setting as opposed to the later line setting where it's approved. Also a press release, we know that this is positive as well. So we're going to be seeing these antibody drug conjugates not only move up into first line metastatic disease, but also in the curative space as well.
Finally, Dr. Hamilton discusses the future direction of ADC therapy, including rationale combination strategies with chemotherapy and other targeted agents.
Combining antibody drug conjugates is a bit interesting. We've looked at several trials combining them with endocrine therapy or immunotherapy or chemotherapy or targeted agents. Sometimes we have to be a little bit careful with antibody drug conjugates, just like we tend to shy away from doublet chemotherapy. We don't want to add toxicity if we're not adding a lot of efficacy for our patients. And so probably the combinations that are most exciting are combinations with immunotherapy where we're really not adding toxicity. But to be honest, I don't see antibody drug conjugates being combined with other chemotherapy at this point.
Thank you for listening. We hope you enjoyed this episode of the VJOncology podcast. To stay up to date with the latest news in oncology, subscribe to our weekly podcast on Apple Podcasts, Podbean, or Spotify. Follow us on X, formerly Twitter, at VJOncology to join in the conversation, and visit VJOncology.com for all the latest updates in breast cancer research and clinical practice.